Good day and welcome. My name is Katerina Tikhonova. I'm from Ukraine. Me and my colleagues from different countries gathered here to help you and to give you the best medical care. Let me explain how the things are working here. First of all, we are receiving an email from you. It contains your request, all information about your disease, medical reports, MRI, X-rays, screens, etc. After that, we are sharing all that information with a certain doctor and taking his medical second opinion, which is MSO for short. The doctor prepares your own treatment plan accordingly. After that, we are taking the cost of the treatment plan from our accounting department and sending the offer to you. If you are accepting the program, from that moment you can start to prepare your plane ticket. We are also helping you with the hotel accommodation, transfers, and arranging your own translator. At your arrival day, we are meeting you with our VIP cars in the airport and bringing to the hospital. We are honored to know you as a Live Hospital family. We are ready to help you 24 hours a day, 7 days in a week. Live Hospital International Patient Service wish you a healthy days.
Здравствуйте, меня зовут Нигина Исмаилова. Я являюсь ответственным лицом по медицинским запросам в клинике ЛИВ для стран СНГ. Наша команда состоит из 40 человек. Мы занимаемся предоставлением второго медицинского мнения. Для этого пациент отправляет нам свои медицинские заключения, лабораторные исследования, если есть радиологические снимки. Специалисты клиники ЛИВ рассматривают и составляют план лечения и диагностики. Алгоритм требующихся обследований, а также их предварительная стоимость отправляется вам на почту. После того, как вы подтверждаете план диагностики и отправляете нам дату вашего приезда, мы организовываем вашу предварительную программу обследования. В случае надобности помогаем вам с резервацией отеля. Также предоставляем вам трансфер с аэропорта в аэропорт. Передаем всю вашу медицинскую информацию, отправленную вами, русскоговорящему переводчику, который будет вас сопровождать в период вашего пребывания в клинике. В день вашего приезда наши коллеги по логистике встречают вас в аэропорту и привозят в клинику ЛИВ. Сейчас вместе с вами посмотрим продолжение. Мы, как клиника Лив, гордимся тем, что нам предоставилась честь узнать вас. Отныне мы являемся частью вашей семьи и готовы вам помочь круглосуточно касательно вопросов вашего здоровья. Международный отдел клиники Лив желает вам благополучных дней.
Live Hospital, which promises to be the future of healthcare with its experienced patient care and guest-oriented approach, opened in Wadi Istanbul. It is that moment which makes you hold on to life, sometimes near a forest, sometimes in daily life. With its advanced diagnostic and treatment methods, that moment actually represents the future. There are some moments which makes you look to the future confidently. Those moments are the future. Live Hospital, the future of healthcare, opened in Wadi Istanbul.
В Вади, Истанбул, открылась больница будущего Live Hospital, отличающаяся опытом в уходе за пациентами и гостеприимным подходом к своим пациентам. Порой расположение на краю леса, порой в жизни наступит момент, когда продвинутые методы диагностики и лечения помогут вам выжить. Этот момент обязательно настанет. Есть моменты, когда вы начинаете смотреть в будущее с уверенностью. Так вот, это именно этот момент будущего. В Вади, Истанбул, открылась больница будущего Live Hospital.
Merhaba, ben Profesör Doktor Levhi Akın. 2014 yılından beri Live Hospital Ulus'tayım. Genel cerrahi ve cerrahi onkoloji uzmanıyım. Aynı zamanda Tıbbi Yürütme Kurulu üyesi olarak idari bir görev de yapmaktayım. Şimdi beraberce Live Hospital Ulus'un içine gireceğiz ve sizler için hastanenin ne kadar güvenli olduğunu gösterebilmek için birlikte bir hastane turu yapacağız. Güvenlik ünitemizi geçtikten sonra tarama bankomuza geliyoruz. Burada uzaktan ateş ölçümümüz yapılıyor. Daha sonra yakın özgeçmişimizle ilgili bir takım sorular sorularak kayda geçiriliyor. Taramamız tamamlandıktan sonra taramayı başarıyla tamamladığımıza dair yakamıza bir etiket iliştirilecek. Hastanede bulunduğumuz süre içinde bu etiketi sürekli yakamızda taşıyoruz. Buyurun. Evet, içeri girdikten sonra önce danışmaya giriyoruz. Burada görmüş olduğunuz gibi sosyal mesafe kuralları açısından gerekli önlemlerimiz alınmış durumda. Girişten itibaren sarı çizgilerimizi devam ettiğiniz zaman onkoloji hastalarımız için özel olarak tahsis edilmiş olan asansörümüze ulaşıyorsunuz. Öncelikle şunu ifade etmek istiyorum. Bizler için en önemli olan şey sizlerin ve hastane çalışanlarımızın güvenliği. Biz sizlerin sağlığı ve tedavisi için buradayız ve hizmete hazırız. Misafirlerimize açık alanlarda ve bekleme bölümlerinde bir takım tedbirler aldık. Gördüğünüz gibi sosyal mesafe kurallarına uyabilmek için işaret gördüğünüz alanlara oturulmuyor, diğer alanlara oturuluyor. Oturulan alanlar her yarım saatte bir temizlik personeli tarafından siliniyor ve temizleniyor. Hastanemizde gerek hastalar, gerek ziyaretçiler, gerekse de refakatçilerle birlikte tüm hastane çalışanları için maske takılması zorunludur. Şimdi bir hasta muayene odasını birlikte göreceğiz. Zaten hep temiz olan yerler. Fakat bu dönemde biz bu işe daha çok konsantre olduk. Her hastadan sonra örtülerimiz zaten değişiyordu, gene değişiyor ama yüzeyler tekrar siliniyor. Sehpalar, her hastadan sonra sandalye kolları, kapı kolları, ışık düğmeleri hepsi temizleniyor. Ayrıca Türkiye'nin dört bir yanındaki hastalarımıza video klinik olarak da hizmet verebiliyoruz. Bilgisayar üzerinden kamera aracılığıyla sizler bizi görebiliyorsunuz, bizler sizi görebiliyoruz. Burada bilgisayardaki bütün sonuçlarınıza ulaşabiliyoruz. Tıpkı yüz yüze görüşüyormuş gibi sonuçlarınızı değerlendirebiliyoruz. Poliklinik hizmetlerimiz güvenli, acil servis hizmetlerimiz güvenli, tetkikleriniz güvenli, ameliyatlar güvenli. Ameliyathane güvenliği için de gerekli tedbirlerimizi aldık. Bu konuda şimdi ameliyathane sorumlumuz Profesör Doktor Didem Dal Hoca ile görüşeceğiz. Buyurun. Profesör Doktor Didem Dal'la birlikteyiz. Sayın hocam, bu süreçte ameliyatlarla ilgili ne gibi tedbirler aldık?
Bu hassas dönemde kesinlikle sağlığınızı ihmal etmeyin. Sağlığınız için gereken tetkikler, gerek bir ameliyat, herhangi bir işlem gerekiyorsa güvenle, doktorlarınıza güvenerek, hastanelerinize güvenerek gelebilirsiniz. Çünkü onlar sizler için, sizlerin güvenliği için tüm tedbirleri alıyorlar. Aynen kendi sağlıkları ve güvenlikleri gibi sizlere de her tür hizmeti sunmaya hazırlar. Bizler de bunları yapmaya çalışıyoruz.
Benimle bu hastane turuna katıldığınız için teşekkür ederim. Live Hospital Ulus'u sizler ve hastane personelimiz için mümkün olan en güvenli hale getirdiğimizi umuyoruz. Sizler için buradayız ve hizmete hazırız. Tedavilerinize devam etmek istiyoruz. Unutmayınız, güvenliyiz ve sizi de güvenli tutmak için buradayız.
Good morning, everyone. My name is Günyal Özdemir. I'm a pediatric hematologist at Live Hospital Ulus. Today, I'm going to talk about an approach to coagulation tests in the pediatric population. And we are going to also talk about some cases. So the title of my talk is Approach to Abnormal Coagulation Test in Children, and it will be a case-based discussion. So I'm going to talk a little bit about physiology first. What is hemostasis? Hemostasis is the maintenance of viscosity of blood in the vessels. That means spontaneous stopping of all bleedings by the body. If there is a bleeding in the body by a trauma or injury, this bleeding will be stopped by the coagulation, and this will be achieved by clot formation, and the bleeding will stop. But this clot will also be degraded by fibrinolysis, and this will be followed by healing and this is called hemostasis in general. So there is a hemostatic balance in the body. We don't see bleeding and we don't see thrombosis in normal conditions. There is a balance that stops bleeding and that prevents also thrombosis. And this is achieved by the anticoagulants and procoagulants in the body. If there is a disequilibrium, if one is higher or lower than the other, then we'll see an imbalance in the hemostatic balance. So hemostasis actually is made of two phases. We have a primary hemostasis, and this is by the formation of a platelet plaque after bleeding, and then that is followed by secondary hemostasis, which is also called coagulation, and this is by the formation of fibrin in the body. If we see a rupture or an injury in the body, then the first thing that will happen is the primary hemostasis, and this will be by formation of a platelet plaque. But this platelet plaque will need to be also covered by a fibrin mesh, and then this will follow by repair.
Начально отвечает заранее закупирование сосудистых стран, сужение сосудов, адгезия тромбоцитов, агрегация и сокращение тромбоцитов. Вторично отвечает за формирование фибрильного сгустка, гарантирующий герметизацию поврежденных областей, облегчая ее восстановление. Активация фактора свертывания за секунду, образование фибрины в течение нескольких минут, фибринолиз.
So
Активация.
So primary hemostasis is responsible for the early plugging of vascular injuries. And secondary hemostasis is responsible for providing fibrin clot to guarantee the sealing of the injured region, facilitating its repair.
Как и говорила, начально отвечает за раннее закупоривание сосудистых травм, а вторично отвечает за формирование фибрильного сгустка.
How is primary hemostasis achieved? There are three steps. The first step is vasoconstriction, and this is an immediate reaction. The second one is platelet adhesion, and this occurs within seconds. And the third one is platelet aggregation, and this also occurs within minutes. The secondary hemostasis is by activation of coagulation factors and formation of fibrin. So normal hemostasis starts with vasoconstriction. And after that, we need a platelet plaque formation. And this is by platelet adherence to damaged vessels. And after that, platelet aggregation. So for the primary hemostasis, we first need the platelets to adhere to the subendothelium. And this leads to platelet activation. And after platelet activation, the platelet aggregates. And this facilitates integration of the hemostasis clot. So you see here the endothelium, and the round yellow points are representative of erythrocytes, and these cylindrical ones represent thrombocytes. So when an injury happens, by the help of von Willebrand factor, the platelets come and adhere to the endothelium. And also there is the reaction between collagen and platelets. After that, after this adherence, platelets activate by recruiting other platelets, and they release some ADP and thromboxane, and this increases the reaction, and there's a change in the shape, and then we get a platelet aggregate. After that, this is the primary platelet plaque. We need fibrinogen to form fibrin, a fibrin mesh around this platelet plaque. So this was the primary hemostasis. The secondary hemostasis is by forming stable fibrin from fibrinogen, and that makes the first platelet plaque, first thrombus, more potent. Secondary hemostasis involves a series of interactions between coagulation factors, and they occur mainly on the surface of the activated platelets. And this results in generation of a thrombin burst and formation of a hemostatic plaque at the site of vascular injury. So this is how coagulation looks like. It starts, the hemostasis starts with the platelets. There's the initiation phase and amplification phase, and different coagulation factors are activated and they are in a cascade. They activate each other. And then we have the first thrombin burst. And this thrombin also increased the activation of the cycle. And at the end, we get fibrin from fibrinogen by the help of thrombin. And this helps a cross-linked fibrin clot by inclusion of factor 13. This is the very simple cascade to show the coagulation cascade. There's an intrinsic pathway, and there is an extrinsic pathway, and there's a common pathway. And this scheme helps us to understand better the coagulation stages, which are PT and APTT. So after this physiology of hemostasis, we can move to the bleeding disorders. What are bleeding disorders? Bleeding disorders are congenital or acquired impairment of hemostasis in the body, causing increased bleeding. So the bleeding tendency may be due to first to the vessels, because in the coagulation, as I have mentioned, it starts with vasoconstriction, so it includes the vessels. If there is a problem in the vessels, we will see a bleeding tendency. Then the cells, which are mainly thrombocytes. If there's a problem with the thrombocytes, we won't have a platelet plaque, so we will have a problem in the primary hemostasis, and we will have a bleeding tendency. And the third one is the enzymes and factors, which are mainly the coagulation factors. If there's a defect in the coagulation factors, we will have a bleeding disorder. So why is it important? Because it is important because patients with bleeding disorders may die or become handicapped due to mainly bleeding. And this bleeding may be spontaneous, after trauma, or after surgery. So it's very important to detect, to diagnose and treat these bleeding disorders. And how do we classify the bleeding disorders? As we have talked about the physiology of hemostasis, we also classify the bleeding disorders according to the pathogenesis. So if there is a problem in the primary hemostasis, that's a primary hemostatic disorder. If there's a problem in the secondary hemostasis, that's a secondary hemostasis disorder. So let's remember what we had in the primary hemostasis. There was the vasculature, there is the vasoconstriction, so there can be a vascular problem. And there are mainly thrombocytes which adhere, aggregate, and form the platelet plaque. If there's thrombocytopenia, that means that there's a reduction in the thrombocyte number. Or if there's a thrombocytopathy, which means there is a normal or sometimes reduced number of thrombocytes, but there is a problem in the function of thrombocytes, then we will have a primary hemostasis disorder. So last month, there was another meeting for the primary hemostasis disorders. Professor Dr. Trajat Jalkan talk about the thrombocytopenias in children. So today I'm not going to talk about thrombocytopenias or thrombocyte problems. I'm going to talk about the secondary hemostatic disorders, which are either factor deficiencies or inhibitors against the factors. So if we have a bleeding, there's a problem either in the primary hemostasis or secondary hemostasis. What are the diseases for the primary hemostasis? The child may have a thrombocytopenia or a qualitative functional platelet disorder. And what are the secondary hemostasis diseases? These are diseases related to coagulation factors. There's hemophilia A, hemophilia B, hemophilia C, or other rarer bleeding disorders. And one disease has a function both in the primary hemostasis and secondary hemostasis, and that is the von Brabant factor. As I have shown you a slide, von Brabant factor has a function in the adherence of platelets to the endothelium. Also, it carries factor 8 in the plasma. So if there is a problem with von Brabant factor in the body, and it is called von Brabant disease, then the patient will have both a primary hemostasis and a secondary hemostasis problem. So how do we approach a child with a suspected bleeding disorder of an abnormal coagulation test? So as in all diseases, the key elements are history, physical examination. Laboratory measurements always comes as the last step, because if we don't have a good history of the patient, or if we don't examine the patient fully, it's really impossible to interpret the laboratory measurements, because without the history and examination, they are sometimes misleading. We can have normal primary laboratory tests in a patient with a bleeding disorder, or sometimes we can see abnormal tests in normal people. So we always need the history and physical examination. So who is this patient? The age is very important. If this bleeding started very late in life, for example, in adulthood, we don't suspect inherited or congenital disease, because usually inherited or congenital diseases start in childhood. The sex of the patient is important, because the inherited diseases are sometimes autosomal recessively inherited, sometimes they are X-linked diseases, and if this is a disease, X-linked disease, we see mostly in men. We don't see in girls or in women. The racial background is important, because some diseases are prevalent in some countries or in some races. And of course, the family history is very important, because if there's other people in the family with similar findings, that would also help us to make a diagnosis. So when is this complaint started? We need to understand the disease state of the patient. If it's a totally normal patient, if the patient doesn't have any abnormality other than this bleeding problem, that's probably an isolated bleeding disorder. But sometimes some bleeding problems may also be seen in some chronic diseases, like in liver diseases or in kidney diseases. We can see thrombocyte function defects in chronic kidney failure, or in some liver diseases, because the coagulation factors will not be produced in the liver due to liver failure. We can see also bleeding disorders. So we need to understand the patient fully. Did the bleeding started after trauma, after surgery, or was it spontaneous? That's also important for us. Was there any drugs that the patient is using? If, for example, the patient is on some kind of aspirin or some non-steroidal anti-inflammatory drug, they might also cause some platelet problems. And the time of onset of the complaints is important, and the cause of the bleeding is important. Where does this patient bleeds? Is it a mucosal bleeding? Is it a bleeding after surgery? If it's a muscle or hemarthrosis bleeding, if it's an intracranial major bleeding, these are also other findings that we need to really understand. The site, as I mentioned, is important. And what is the physical characteristics of the bleeding? If it's a petechial bleeding, if it's a purpura, if it's an ecchymosis, of it's a hematoma, this will also help in diagnosis. So when we do the physical examination, we really need to focus on any skin lesions, including any petechia. For example, we usually see petechia in children with primary hemostatic defects, like thrombocytopenias or qualitative platelet disorders. There's usually a mucosal bleeding, mucocutaneous bleeding. There's idle skin lesions or any petechia, for example, inside the mucosa, like in the mouth. We don't see an organomegaly in a, for example, a coagulation disorder patient, but if the patient has leukemia and the thrombocytopenia is due to leukemia, we will see hepatosplenomegaly or lymphadenopathy. Infections are important. For example, some infections may cause bleeding by themselves, liver dysfunction, renal dysfunction, and rheumatologic findings are important. Some rheumatologic diseases may cause, for example, thrombocytopenia, like lupus, and then this patient may have bleeding due to that rheumatologic disease. So primary hemostatic problems are thrombocytopenias and platelet functional defects. And to diagnose these diseases, we need to get a platelet count. And this is how we do it. We get a blood count, complete blood count from the patients. And we can also make a peripheral blood smear, and this will also help us. Bleeding time is sometimes helpful, sometimes not. Bleeding time was used frequently in the past, but we don't use it very much nowadays. And the reason for that, it's very difficult to do a standard bleeding time. The results usually depend from lab to lab. And we also, the specificity and the sensitivity of the test is very low. So, but if we get a bleeding time and if it's prolonged, that may also show a primary hemostatic problem. So, other than that, there are also some other more detailed tests that are not done in every laboratory, and that's why it's very difficult sometimes to diagnose a patient with platelet function abnormality, because if you have a normal platelet count and, for example, a normal bleeding time, you can still have a platelet function problem. And to diagnose a platelet functional problem, you need to use a platelet function analyzer and a platelet aggregation test or flow cytometry. And these tests are not performed in all labs in the world, so it may be difficult to diagnose a platelet function defect, like, for example, Glanzmann disease or Bernard-Solier disease. The thing about the Bernard-Solier, in Bernard-Solier, you also have thrombocytopenia, so it's easier. But for the Glanzmann thrombosthenia, you need to do a platelet aggregation or flow cytometry test to make a definite diagnosis. So these patients are not diagnosed for a long time in their life. And what are the problems related to the secondary hemostasis problem? And the main thing that we see is factor deficiencies. So, and the global tests that show coagulation abnormalities are PT and APTT. And as you all know, PT and APTT are almost done in every lab, everywhere, but sometimes they are not enough. And you need to do specific factor tests. in some diseases. For example, in factor 13 deficiency, the PT and APTT are totally normal. So if you don't make a specific test just for factor 13, it's impossible to diagnose a factor 13 patient. And sometimes they're abnormal, but it does not show a bleeding disorder. For example, APTT may be prolonged in factor 12 deficiency, but factor 12 deficiency does not cause bleeding. So if you have a patient with a prolonged APTT, you need to understand why that PTT is prolonged. Because if it's only factor 12 deficiency, this patient does not have a bleeding disorder. So it's important to look at the specific factor levels in the blood. So we have the global tests, which are PT and APTT for the secondary hemostasis defects. We need to measure the single coagulation factor. And sometimes there are some inhibitors in the blood, and they may be caused with different things, different diseases, like due to infections, due to some rheumatologic diseases. And these inhibitors, some may block the coagulation factors. And it's important to understand whether the patient has an inherited coagulation factor deficiency or an acquired inhibitor. So we use a mixing test to detect the inhibitors in the blood. So prothrombin time, PT, measures the integrity of the extrinsic system in the body. APTT, activated partial thromboplastin time, measures the integrity of the intrinsic system, intrinsic coagulation system. So let's remember what was in the intrinsic pathway and what was in the extrinsic pathway. So extrinsic pathway starts with factor 7. So if you have an isolated prolonged PT, that shows factor 7 deficiency. But if you have an isolated prolonged APTT, that is either due to factor 12 deficiency, factor 11 deficiency, factor 9 deficiency, or factor 8 deficiency. After that point, there is a common pathway which starts with factor 10, and then factor 5A as cofactor, and then this turns prothrombin to thrombin, and then fibrinogen to fibrin. So if there is a factor, for example, 10 deficiency, because it is in the common pathway, you will have both prolonged APTT and prolonged PT. So any defect in the common pathway causes a prolongation of both these tests. If there's only defect in the intrinsic pathway, there will be isolated prolonged APTT. If there is any defect only in the extrinsic pathway, that will cause prolonged PT. So this is the summary. So PTT evaluates the factor 12, 11, 9, 8, and then common pathway 10, 5, 2. 2 is prothrombin, and then 1 is fibrinogen. And PT evaluates factor 7 as isolated extrinsic pathway, and then in the common pathway it also evaluates factor 10, 5, 2, and 1. And then at the end we have the factor 2 from factor 1, factor 2 to factor 2A, and then fibrinogen factor 1 to fibrin. So APTT, the normal range actually depends on the test system. So it's impossible to compare results from different laboratories. If you have a test from one laboratory, then you need to check the normal range in that laboratory, because the different laboratories usually use different activators for the test. But in general, it's normally it's between 10 to 14 seconds. And also depending on the assay, depending on the laboratory which use different assay, the normal range is different from one lab to other. But normally APTT is around 26 to 36 seconds. So let's talk about a few diseases that cause coagulation factor defects. The first one is hemophilia. So hemophilia, there are different hemophilias, hemophilia A, B, and rarely we see C. But the most common one is hemophilia A. And hemophilia A is factor 8 deficiency. And hemophilia B is factor 9 deficiency. So hemophilia A is more common, almost 6 times, 5 to 6 times more common than hemophilia B. And it's very important to understand that in these inherited diseases, although they are inherited, sometimes there is no family history because they may be due to some de novo new mutations. So in 30% of the cases, there is no family history. So this is the first child in the family who has hemophilia. So these two diseases are due to mutations in the genes located on the X chromosome. That means they are X-linked. So hemophilia A and B are seen in boys, in men, because they are in the X chromosome. The second disease is von Willebrand disease, and this is the most common clotting factor deficiency in the world, but patients are usually not diagnosed for a long time or later in life. It causes a problem both in the primary hemostasis and in the secondary hemostasis. And the reason is that because it has a role in platelet adhesion as well as it carries the factor 8 in the plasma. So in the primary hemostatic problems, we usually see mucocutaneous bleedings. In the secondary hemostatic problems, there's usually more severe kind of bleeding, like bleeding in the muscle, hematomas, bleeding inside the joints, which is hemarthrosis. But in von Willebrand disease, we see a combination of these. Patients may have both mucocutaneous bleeding as well as bleeding in the muscle or joints. This is inherited autosomal recessively, rarely in some cases autosomal dominantly, but mainly autosomal recessively. So we see von Willebrand disease both in women and men. And as I mentioned, there's a both primary and secondary hemostatic defect. There are also some rare bleeding disorders, and they are very rare. But we see them, especially in countries where there's a high level of consanguinity. So we can have a patient with factor 7 deficiency, factor 5 deficiency, factor 10 deficiency, factor 13 deficiency, fibrinogen defects like afibrinogenemia. We can also see some combined factor deficiencies, factor 11 deficiency. But in factor 12 deficiency, it's not a bleeding disorder. We don't see bleeding. It just causes a prolonged APTT. So the most common one is factor 7 deficiency. And most are autosomal recessively inherited. Some rare fibrinogen defects may be inherited autosomal dominantly. So we see these diseases both in women and men. Also, there's a possibility of a circulating anticoagulant, which is an inhibitor in the blood, that may also cause, because the patient was treated, for example, by heparin, or there was heparin in some kind of heparin in the tubes or in the port, for example, in catheters, that also cause prolonged tests. Or there can be some inhibitors against specific factors. For example, in hemophilia patients, sometimes they produce antibodies against factor 8 or factor 9 that is given as a drug from outside. So the body does not recognize these drugs, and they may produce some antibodies against them, and this is called inhibitors. Or some inhibitors may be caused by some rheumatologic diseases like lupus. You can see lupus anticoagulant. So you see a prolonged APTT. To understand if this APTT prolongation is due to inhibitors, you need to do a mixing test. And also we see some consumptive coagulopathies. That means the coagulopathy is not inherited, but this is acquired. There are hemolytic uremic syndrome, some sepsis, some ulcerative complications. There is some kind of trauma or liver disease, and it consumes the coagulation factors, or in some liver diseases, they are not produced enough. So you can also see a coagulation defect in the patient. So for all these coagulation defects, actually the ultimate goal is a cure. But for a cure, for example, in an inherited diseases, they don't go away. The only thing that you can do actually is gene therapy, and this is nowadays is a possibility for some patients with, for example, hemophilia A and hemophilia B. There is a really good advancement in the gene therapy in hemophilia. But if there is no possibility of a cure, then the second possibility is that we should prevent all bleedings if possible. And that is done by prophylaxis in some diseases. For example, if you have a severe hemophilia A, patients are put on prophylactic factor treatments early in life from childhood. But other than that, all bleeding episodes that occur should be addressed immediately in a patient with a bleeding disorder and should be treated by an effective, safe treatment. So what do we use for bleeding disorders? Of course, we use blood products because there is a problem in the blood. If there is a problem with the platelets, if the platelet number is low, we use a platelet suspension. Also, we use platelet suspension for platelet functional defects. If there is a problem in the coagulation system, we can always use fresh frozen plasma. Actually, it's better to use a viral inactivated plasma, but it cannot be found everywhere. For example, if the patient has a low fibrinogen, we can use a fibrinogen concentrate. There are prothrombin complex concentrates which contain factor 2, 7, 9, and 10. We can use these complex concentrates, for example, for factor 10 deficiency. For factor 7 and factor 9 deficiency, there is a specific concentrate. For von Willebrand disease, we can use a von Willebrand concentrate. For hemophilia A, we use factor 8 concentrates. For hemophilia B, we use factor 9 concentrates. For factor 7 deficiency, we use factor 7 concentrates, which are available. Also, these are all available in Turkey. For factor 13 concentrate, for factor 13 deficiency, we use factor 13 concentrate. If there is an antithrombin deficiency, we use antithrombin. If there is a protein C deficiency, we use recombinant protein C. So it's important to understand what kind of coagulation defect the patient has. If there's not a specific treatment for that, we can use fresh frozen plasma because, for example, for factor 5 deficiency in the world, there is no specific factor 5 concentrate yet. It will be produced hopefully in near future. And so in a patient with factor 5 deficiency, you can only use fresh frozen plasma. So let's talk about some cases now. So our first case is a 31 weeks old premature baby boy. So he was treated in intensive care unit and he had an intraventricular bleeding. And a number of tests were done. His CBC was normal. He had a polycythemia. His hematocrit was higher than normal. And also his APTT was abnormal. So now we have a small baby, premature baby. So this patient has an intracranial bleeding, and this intracranial bleeding can be due to prematurity, but also this can be due to a bleeding disorder. So in a small baby, it's very difficult to get a history because there is no previous history of this baby actually. This baby was born and then put on intensive care unit. So it's very difficult. But let's think that this patient also has no family history, but there's still a possibility of a bleeding disorder. So what do we do with this prolonged APTT? So the first thing we need to do when we see a prolonged APTT is to understand whether this is really prolonged, because the age has an effect on PT and APTT. Most of the coagulation factors are physiologically low in small children or babies. So because they're physiologically low, the PT and APTT are higher than older children in small children. For example, in a 5-day-old baby, the upper limit of APTT is 50. So it's really higher than an adult. In an adult, it's 34, for example. So we need to check the age-specific results for PT and APTT. And also, in the premature baby, they're lower than normal mature babies. So it's difficult to understand whether it's physiologically high or abnormal. But in this case, it is abnormal because, as you see, the physiological upper limit is 50. However, in this child, it was 58 seconds. So it's high. So what was done? So when the patient was 5 days old, the doctors in the intensive care unit, because the APTT was prolonged, and remember that it's prolonged in the extrinsic pathway disorders, all the extrinsic pathway factors were sent, and they found 23% factor 9. So normally it should be between 50 to 100%. So they thought this was a case with mild hemophilia B, and they referred the patient to hematology oncology. But we should interpret the results. First, we need to interpret whether this APTT, we check the effect of the age, but we should check other things. So remember that all coagulation factors are low, especially in the premature babies. So factor 9, that's fine, is normally around 18% in a premature baby. So a 23% factor 9 in a premature 5-day-old patient is not abnormal. It's physiologically normal. So this result was not abnormal. So this was interpreted wrongly. This patient doesn't have mild hemophilia B. And the second thing, for the right results, we need to get the tests perfectly. We need to check this PT and APTT in a blue tube container. And physiologically, in these containers, there's 1 part citrate and 9 parts plasma. But the test should be performed as soon as they are gathered. So there's the effect of elevated hematocrit on APTT. So if your hematocrit is normal, then the citrate level to blood level is an equilibrium. But if your hematocrit is high and you have an reduced plasma, then the equation of 1 part citrate to 9 parts blood is not equal in this case, and then because there will be more citrate compared to the plasma, you will get an elevated APT. So if the patient has an elevated hematocrit, the lab should always check the hematocrit level of the patient first, and then make the interpretation of APTT accordingly. So in this way, the APTT was prolonged due to high hematocrit. The factor IX level was normal according to age. So we checked the factor IX level after 3 months of age, and they were totally normal. So this baby did not have any bleeding problem. This baby doesn't have a coagulation disease. This baby probably had an intraventricular bleeding just due to prematurely. So it's really important to interpret the result in the right way. The second case is an 8-year-old girl, and this patient has epistaxis and was hospitalized for bleeding, and the bleeding stopped by tamponade and plasma infusion. This is important because we see epistaxis in children all the time, but which one is important, which one is not important, it's sometimes difficult to differentiate. But if you look at this case, this phase was hospitalized for bleeding, and the bleeding could only stop by a tamponade and plasma infusion. And this is an important detail in the history. This wasn't a simple epistaxis. This was actually a complicated epistaxis. And when we check the family history, as I mentioned, it's very important. The grandfather dies due to bleeding in an operation. An aunt bleeds during myomectomy and hysterectomy was performed. And the patient's mother was in hypotensive shock during normal labor and was transfused. And this is a very important family history. This patient probably have a bleeding disorder with this family background. So we checked the primary tests, and they were all normal. Complete blood count was normal. Peripheral smear was normal. PT and APTT was normal. And fibrinogen was normal. But why is this patient bleeding? So sometimes the primary tests are not enough. If you really suspect that a patient has a bleeding disorder, you need to perform detailed tests. These tests does not mean that the patient doesn't have a bleeding disorder. So what are the other tests we can do? We can do a thrombocyte aggregation test for a qualitative functional platelet disorder. We can check the specific factor levels, and we can check the von Willebrand antigen and also activity level. So in most cases of von Willebrand disease and in some mild hemophilia cases and in factor 13 deficiency and in some other bleeding disorders, coagulation disorders, PT and APTT are completely normal. So it's important to remember this. And also von Willebrand disease is the most common inherited bleeding disorder. And sometimes, for example, epistaxis can be the only sign, or for example, menorrhagia can be the only sign. So you don't see any bleeding complaint until the patient has the first menarche. So it's important to remember this. And also some patients may only bleed after some kind of surgery, for example, typically after tooth extraction. How can we diagnose von Willebrand disease? We need to check the antigen and RICOF and factor 8 level in the blood. But in some specific von Willebrand disease subgroups, you may also see a normal antigen RICOF and factor 8 level, and the only finding may be in thrombocytopenia, for example. So it's not easy to diagnose von Willebrand disease. The last case is a 12-year-old girl. There is a history of menorrhagia. There's consanguinity between the parents, and it's very important for autosomal recessive disease. So in the family history, a sister died due to bleeding from umbilical stump. An aunt's child died due to bleeding. An uncle's daughter died due to bleeding after surgery. This is then, again, an important family history. So when the patient presented us, the patient has anemia, so there was severe bleeding, and also both the PT and APTT were prolonged, and fibrinogen level was undetectable in the blood. So this is a 13-year-old child who was not diagnosed until 13 years of age with severe bleeding episodes, actually. So we diagnosed the patient as afibrinogenemia. There is no fibrinogen in the blood. So after that, this patient presented us with fever and abdominal pain, and there was a septated lesion in the spleen. And we first thought this was an abscess, but in ours, the patient was in hypovolemic shock, and there was fluid inside the abdomen. And this patient actually had spontaneous splenic rupture. And this is very interesting because we actually published this case because you can see spontaneous splenic rupture in patients with congenital afibrinogenemia. And this was reported before. So some bleeding disorder patients may have interesting findings. These are the other case reports in the literature. You can see splenic rupture in afibrinogenemia, and the only treatment is actually splenectomy. Otherwise, the patient may die. So we our patient splenectomy was performed, and this is the picture of the spleen of our patient. So as you see, it has bleeded majorly inside the spleen during rupture, and this was the totally spontaneous rupture. The patient didn't have any history of trauma or injury. So congenital fibrinogen disorders are very rare, but I have actually 5 patients. If there is no fibrinogen in the blood, it's called afibrinogenemia. If it's low, it's called hypofibrinogenemia. If there is a functional defect, it's called dysfibrinogenemia. And for afibrinogenemia and hypofibrinogenemia, you need to check the level in the blood, but it's very difficult to diagnose dysfibrinogenemia. You need some other tests. So what are the clinical manifestations of afibrinogenemia? So bleeding is the main symptom. And the first manifestation may be prolonged bleeding from the umbilical stump. Diagnosis may be delayed due to surgery or trauma. You can see bleeding in almost all tissues, including the muscle, but hemoarthrosis, which we see in hemophilia patients, is very rare. And spontaneous intracranial bleeding is the leading cause of death. And some patients with hypofibrinogenemia may have some abortions in the first trimester. So you see, this was a case report from Turkey, and there was 16 patients, term babies with intracranial bleeding, and 1 baby was diagnosed as afibrinogenemia. So also, another interesting finding in patients with afibrinogenemia are bone cysts. These patients may have multiple bone cysts, and these bone cysts may cause some pain in the joints or in the bone. And the treatment is plasma-derived fibrinogen concentrates. They're in the market. We also find them in Turkey. But if you cannot find fibrinogen concentrate in your country or in your center, you can also either use fresh frozen plasma or cryoprecipitate. Also, in all the bleeding disorder patients, you can also use antifibrinolytics and also oral contraceptives for menorrhagia. And in some minor surgeries, especially, for example, in tooth extraction or for some circumstances, you can also use fibrin glues. So this is the end of my talk. If you have any questions, I am happy to answer them.
Good day and welcome. My name is Katerina Tikhonova. I'm from Ukraine. Me and my colleagues from different countries gathered here to help you and to give you the best medical care. Let me explain how the things are working here. First of all, we are receiving an email from you. It contains your request, all information about your disease, medical reports, MRI, X-rays, screens, etc. After that, we are sharing all that information with a certain doctor and taking his medical second opinion, which is MSO for short. The doctor prepares your own treatment plan accordingly. After that, we are taking the cost of the treatment plan from our accounting department and sending the offer to you. If you are accepting the program, from that moment you can start to prepare your plane ticket. We are also helping you with the hotel accommodation, transfers, and arranging your own translator. At your arrival day, we are meeting you with our VIP cars in the airport and bringing to the hospital. We are honored to know you as a Live Hospital family. We are ready to help you 24 hours a day, 7 days in a week. Live Hospital International Patient Service wish you a healthy days.
Здравствуйте, меня зовут Нигина Исмаилова. Я являюсь ответственным лицом по медицинским запросам в клинике ЛИВ для стран СНГ. Наша команда состоит из 40 человек. Мы занимаемся предоставлением второго медицинского мнения. Для этого пациент отправляет нам свои медицинские заключения, лабораторные исследования, если есть радиологические снимки. Специалисты клиники ЛИВ рассматривают и составляют план лечения и диагностики. Алгоритм требующихся обследований, а также их предварительная стоимость отправляется вам на почту. После того, как вы подтверждаете план диагностики и отправляете нам дату вашего приезда, мы организовываем вашу предварительную программу обследования. В случае надобности помогаем вам с резервацией отеля. Также предоставляем вам трансфер с аэропорта в аэропорт. Передаем всю вашу медицинскую информацию, отправленную вами, русскоговорящему переводчику, который будет вас сопровождать в период вашего пребывания в клинике. В день вашего приезда наши коллеги по логистике встречают вас в аэропорту и привозят в клинику ЛИВ. Сейчас вместе с вами посмотрим продолжение. Мы, как клиника Лив, гордимся тем, что нам предоставилась честь узнать вас. Отныне мы являемся частью вашей семьи и готовы вам помочь круглосуточно касательно вопросов вашего здоровья. Международный отдел клиники Лив желает вам благополучных дней.
Live Hospital, which promises to be the future of healthcare with its experienced patient care and guest-oriented approach, opened in Wadi Istanbul. It is that moment which makes you hold on to life, sometimes near a forest, sometimes in daily life. With its advanced diagnostic and treatment methods, that moment actually represents the future. There are some moments which makes you look to the future confidently. Those moments are the future. Live Hospital, the future of healthcare, opened in Wadi Istanbul.
В Вади, Истанбул, открылась больница будущего – Live Hospital, отличающаяся опытом в уходе за пациентами и гостеприимным подходом к своим пациентам. Порой расположение на краю леса, порой в жизни наступит момент, когда продвинутые методы диагностики и лечения помогут вам выжить. Этот момент обязательно настанет. Есть моменты, когда вы начинаете смотреть в будущее с уверенностью. Так вот, это именно этот момент будущего. В Вади, Истанбул, открылась больница будущего – Live Hospital.
Merhaba, ben Profesör Doktor Levhi Akın. 2014 yılından beri Live Hospital Ulus'tayım. Genel cerrahi ve cerrahi onkoloji uzmanıyım. Aynı zamanda Tıbbi Yürütme Kurulu üyesi olarak idari bir görev de yapmaktayım. Şimdi beraberce Live Hospital Ulus'un içine gireceğiz ve sizler için hastanenin ne kadar güvenli olduğunu gösterebilmek için birlikte bir hastane turu yapacağız. Güvenlik ünitemizi geçtikten sonra tarama bankomuza geliyoruz. Burada uzaktan ateş ölçümümüz yapılıyor. Daha sonra yakın özgeçmişimizle ilgili bir takım sorular sorularak kayda geçiriliyor. Taramamız tamamlandıktan sonra taramayı başarıyla tamamladığımıza dair yakamıza bir etiket iliştirilecek. Hastanede bulunduğumuz süre içinde bu etiketi sürekli yakamızda taşıyoruz. Buyurun. Evet, içeri girdikten sonra önce danışmaya giriyoruz. Burada görmüş olduğunuz gibi sosyal mesafe kuralları açısından gerekli önlemlerimiz alınmış durumda. Girişten itibaren sarı çizgilerimizi devam ettiğiniz zaman onkoloji hastalarımız için özel olarak tahsis edilmiş olan asansörümüze ulaşıyorsunuz. Öncelikle şunu ifade etmek istiyorum. Bizler için en önemli olan şey sizlerin ve hastane çalışanlarımızın güvenliği. Biz sizlerin sağlığı ve tedavisi için buradayız ve hizmete hazırız. Misafirlerimize açık alanlarda ve bekleme bölümlerinde bir takım tedbirler aldık. Gördüğünüz gibi sosyal mesafe kurallarına uyabilmek için işaret gördüğünüz alanlara oturulmuyor, diğer alanlara oturuluyor. Oturulan alanlar her yarım saatte bir temizlik personeli tarafından siliniyor ve temizleniyor. Hastanemizde gerek hastalar, gerek ziyaretçiler, gerekse de refakatçilerle birlikte tüm hastane çalışanları için maske takılması zorunludur. Şimdi bir hasta muayene odasını birlikte göreceğiz. Zaten hep temiz olan yerler. Fakat bu dönemde biz bu işe daha çok konsantre olduk. Her hastadan sonra örtülerimiz zaten değişiyordu, gene değişiyor ama yüzeyler tekrar siliniyor. Sehpalar, her hastadan sonra sandalye kolları, kapı kolları, ışık düğmeleri hepsi temizleniyor. Ayrıca Türkiye'nin dört bir yanındaki hastalarımıza video klinik olarak da hizmet verebiliyoruz. Bilgisayar üzerinden kamera aracılığıyla sizler bizi görebiliyorsunuz, bizler sizi görebiliyoruz. Burada bilgisayardaki bütün sonuçlarınıza ulaşabiliyoruz. Tıpkı yüz yüze görüşüyormuş gibi sonuçlarınızı değerlendirebiliyoruz. Poliklinik hizmetlerimiz güvenli, acil servis hizmetlerimiz güvenli, tetkikleriniz güvenli, ameliyatlar güvenli. Ameliyathane güvenliği için de gerekli tedbirlerimizi aldık. Bu konuda şimdi ameliyathane sorumlumuz Profesör Doktor Didem Dal Hoca ile görüşeceğiz. Buyurun. Profesör Doktor Didem Dal'la birlikteyiz. Sayın hocam, bu süreçte ameliyatlarla ilgili ne gibi tedbirler aldık?
Bu hassas dönemde kesinlikle sağlığınızı ihmal etmeyin. Sağlığınız için gereken tetkikler, gerek bir ameliyat, herhangi bir işlem gerekiyorsa güvenle, doktorlarınıza güvenerek, hastanelerinize güvenerek gelebilirsiniz. Çünkü onlar sizler için, sizlerin güvenliği için tüm tedbirleri alıyorlar. Aynen kendi sağlıkları ve güvenlikleri gibi sizlere de her tür hizmeti sunmaya hazırlar. Bizler de bunları yapmaya çalışıyoruz.
Benimle bu hastane turuna katıldığınız için teşekkür ederim. Live Hospital Ulus'u sizler ve hastane personelimiz için mümkün olan en güvenli hale getirdiğimizi umuyoruz. Sizler için buradayız ve hizmete hazırız. Tedavilerinize devam etmek istiyoruz. Unutmayınız, güvenliyiz ve sizi de güvenli tutmak için buradayız.
Okay. Hello everyone. I am Mehmet Taşdemir and I am a pediatric nephrologist, and I would like to talk with you about hematuria in children and how can we manage these patients. I have some cases, and if you have any question, you can ask whenever you want. Okay, let's start. As you know, hematuria means the presence of blood or red blood cells in the urine. And let's start a case. Our case one is a 5-year-old girl, and she presents to her primary care physician for routine checkup with no complaints, and physical exam findings and medical history unremarkable, and urinalysis revealed us 3+ blood and no protein. And I have some questions for you. If you would like to answer it, please write in Q&A section. What should our first step, and what's our differential diagnosis for this child, and how should be our rational approach? And I'm waiting for 10 seconds or a bit more. Okay, we can continue. First step, calm down, because either isolated microscopic or gross hematuria is not a serious condition usually, and a significant bleeding through the urinary system is a very rare condition. But it can be a transient finding with no clinical importance, or an important sign of marker of a severe kidney disease, and we have to be careful about it. In terms of case one, what's the first step? We perform urinalysis 2 or 3 times, and then we assess urine sediment in microscopy, and we differentiate isomorphic or dysmorphic erythrocytes, and I will show you some pictures about it. And for this patient, differential diagnoses are infection, UTI, urinary tract infections, or tuberculosis, or urinary system stone disease, or benign familial hematuria, or trauma, or some anatomic problems, uretero-pelvic junction obstructions, or vesico-urethral reflux. And how should be our rational approach? Urine culture and calcium creatinine excretion, and parents' urinalysis, and PPD for tuberculosis, and hemoglobin electrophoresis for some hemoglobinopathies, and ultrasound is a useful tool. There was no systemic clinical finding and no urinary system abnormality via ultrasonography, and we found normal kidney function tests. And we actually decided this patient has isolated microscopic hematuria. In that condition, we generally follow them urinalysis, repeated urinalysis, and if there is no proteinuria, no hypertension, and normal kidney function, annual follow-up is enough for these patients. And if there is a certain diagnosis, for example, a medication or infection or some hemoglobinopathies, we change our treatment plan. If there is no diagnosis, we perform ultrasound and some blood tests, blood urea nitrogen, and hearing tests for some glomerulopathies and coagulation test. And then you can refer this patient to a pediatric nephrologist. When we turn back case 1, we repeat urinalysis and we found 3+ blood, no protein, and 10 to 12 red blood cells per high power field. And the normal range is, as you know, 5, below 5. And we found increased urine calcium creatinine excretion for this patient, and negative PPD and normal ultrasound. And we diagnosed hypercalciuria for this patient then. Hypercalciuria means calcium excretion above the normal limits for age and for this patient. This is the commonest metabolic abnormality. When we found a kidney stone or hematuria, we generally assess metabolic abnormalities, especially calcium excretion or oxalate excretion. It's a frequent problem. As you see, 30 to 50% of pediatric stone formers have this problem. And symptoms may be hematuria and dysuria, polyuria, polydipsia, abdominal pain, and sometimes they can be asymptomatic. And when we found hematuria and hypercalciuria, we decide to give some treatment, anti-calciuric management for hypercalciuria. What does that mean? Potassium citrate to reduces calcium oxalate supersaturation and increases urine pH. Thiazides reduce urine calcium excretion and restore bone mineral density. And combination therapy with low calcium and oxalate diet and biphosphonate therapy improves bone mineral density and reduces hypercalciuria too. And water is essential for these patients. And again, when we turn back case 1's clinical course, we started calciuric medication, vitamin D discontinuation, and we increased fluid intake and restrict sodium. And we started to give potassium citrate to decrease supersaturation. There was no gross hematuria, no stone formation during follow-up, and microhematuria resolved at 6 months of follow-up. When we want to classify hematuria, it can be macroscopic or microscopic, or symptomatic or asymptomatic, and transient and persistent. And as you can see in this image, hematuria can be associated with a lot of reasons. For example, it can be an infarct or stone or tubulointerstitial nephritis or ureteric stones or problems or bladder problems or urethral trauma or posterior urethral valves or infections or again malignancies, tumors. And the color of urine is an important clue about the origin. If we observe brown or tea-colored urine, we generally think about glomerular origin. If it's red, we generally think about a distal source of urinary tract. You can see the color change of urine, and we can find positive protein results in urinalysis due to blood. Asymptomatic means there is no any symptoms or other abnormal exam findings. And isolated means there is no proteinuria, just hematuria. If you have any question about case 1, you can ask, and I can check question and answer. And I will continue with case 2. But just I want to check the question answer section, and there is no any question. Okay. Case 2, 10-year-old boy, and his complaints: tea-colored urine, headache, malaise and lethargy, facial puffiness, and weight gain. He had sore throat and fever 14 days ago, and we found increased blood pressure because you can see this is above 98 percentile for his age and sex. Periorbital and bilateral peritibial edema, and we found protein and blood in his urine, and red blood cells, erythrocyte cast. And what are our differential diagnoses for his renal problems? How should be our rational evaluation steps, and how is the long-term prognosis are our questions. If you would like to write anything, please write it. Okay. When we observe gross hematuria in a child, we suspect about trauma or urinary tract infections or stones. It's a frequent problem, and glomerular diseases. To evaluate trauma, CT is a useful tool, but you know it has a radiation, and we select some cases for this procedure. And urine culture and repeated urinalysis and ultrasonography for UTI. Ultrasonography, rarely CT for stone disease, kidney stones. Intravenous pyelography is rarely used nowadays. It has a lot of radiation, and we don't prefer it generally. And some metabolic assessment, calcium excretion, oxalate excretion, and other metabolic excretions, and glomerulonephritis. In the presence of hypertension, proteinuria casts, we ordered blood urea nitrogen and creatinine and electrolytes and complete blood count, peripheral smear, complement C3, C4, anti-streptolizin O, anti-nuclear antibody to differentiate glomerular diseases. And then we can make a diagnosis about some glomerular diseases such as post-streptococcal acute glomerulonephritis or IgA vasculitis or other glomerular diseases. If there is no significant finding, we order urine culture, calcium creatine excretion, and parents' urinalysis, PPD, and other simple tests to make a diagnosis. And I would like to remind you about case 2. He had tea-colored urine, headache, malaise, lethargy, facial puffiness, and an infection 14 days ago, and increased blood pressure, hematuria, and proteinuria. It never occurred in the past, and no family history of similar occurrence or renal disease, and no trauma. The problem lists are this: tea-colored urine. It indicates upper tract bleeding, glomerular origin. It's unlikely urinary tract infection. There was no any urinary system symptoms, and it may suggest glomerular diseases. If the patient has malaise or lethargy, we generally think about kidney function deterioration and anemia, uremia, and oliguria, edema, high blood pressure may suggest uremia and renal failure too. And our differential diagnosis for his renal problems, first, glomerulonephritis. It can be acute or chronic. And this is examples: post-streptococcal glomerulonephritis, IgA nephropathy, membranoproliferative glomerulonephritis, and SLE, systemic lupus erythematosus, and some vasculitis. And evaluation steps should be like that. Complement C3 and C4 are useful tools to differentiate post-streptococcal glomerulonephritis and membranoproliferative glomerulonephritis and lupus, systemic lupus erythematosus. You can see the normal and low and high values. And CBC, complete blood count, BUN, creatinine, albumin, electrolytes, urinalysis, urine red blood cell morphology are useful to differentiate kidney failure or hemolytic process or azotemia and severe kidney dysfunction. When we turn back our case 2, he had dysmorphic hematuria, and the normal limit of it should be below 25%, and he had 80% dysmorphic hematuria, increased blood urea nitrogen and creatinine, and low C3, and increased anti-streptolism O. An ultrasound showed us mild increase in echogenicity and size of kidneys. It's non-specific.
Также эти
An initial diagnosis are acute glomerulonephritis and a suspicion of chronic glomerulonephritis. How should be our next plan? I'm checking question answer part, and there is no any question. Okay. Post-infectious glomerulonephritis can happen 1 to 2% of cases of pharyngitis, and there can be some bacterial and viral triggers. Streptococcus is the most frequent one, and there is generally antecedent illness 2 weeks earlier, and acute onset gross hematuria, tea-colored, hypertension, and there can be edema, and low C3, normal or slightly low C4, and high anti-streptolism O titers. And we follow these patients in outpatient clinic, and it can be confirmed by normalization of C3 in 8 to 10 weeks after initial presentation. How can we manage these patients? Generally, it's a self-limiting disease, and we restrict fluid and sodium, and sometimes we need to use some medications, including loop diuretics or vasodilators or some antihypertensives intravenously. And in the presence of hyperkalemia, we use potassium lowering agents and sorry about it. In the presence of hyperkalemia, we use potassium-lowering agents, and most patients do not need hospitalization. And how about long-term prognosis? It's excellent, actually, and generally, almost all children completely recover, and gross hematuria and proteinuria resolve within first 2 weeks. Hypertension and oliguria resolve within first 2 weeks. Microscopic hematuria can persist along 1 year, and long-term kidney functions are always normal, and complement C3 normalizes within 6 to 8 weeks. And our case 2, diagnosed with acute post-streptococcus glomerulonephritis, post-streptococcal glomerulonephritis. We hospitalized him due to high blood pressure and malaise and headache. And we started to give diuretics, furosemide, and calcium channel blockers to control worsening hypertension. And we restrict fluid and sodium. And we started to give penicillin due to positive culture results for group A beta hemolytic streptococcus. And we discharged him after 3 days of hospitalization. Hypertension resolves over the next 2 weeks, and proteinuria and gross hematuria resolved at 3rd week of follow-up. Macrohematuria resolved at 5th day, and BUN creatinine resolved at 10th day, and complement C3 did not normalize at 3 months of follow-up, and macroscopic hematuria persists at 3rd month of follow-up. Then we thought, was it a certain diagnosis or true diagnosis, post-streptococcal acute glomerulonephritis? And unfortunately, there was an attack about gross hematuria again, after an upper respiratory system infection. And then we decided to perform kidney biopsy. The indications for kidney biopsy are kidney failure, hypertension, persistent hematuria, like our patient, persistent proteinuria, and persistent hypocomplementemia, like our patient. And we found mesangial cell proliferation, increased mesangial matrix, basement membrane thickening, and focal splitting. Then we diagnosed membranoproliferative glomerulonephritis type 2. It's a hypocomplementemic glomerulonephritis, and it can present with nephrotic syndrome or asymptomatic proteinuria or hematuria. And it's characterized with low serum complement C3 in 70%. And type 1 progress slowly to end-stage renal disease in 10 to 20 years, but type 2 often progresses rapidly. And proteinuria may be responsive to steroids and ACE inhibitors, angiotensin-converting enzyme inhibitors. And when we turn back case 2's clinical course, he is diagnosed with MPGN type 2, and he is following closely with our team. And the final situation is a B increased, mildly increased, creatinine mildly increased, and mild proteinuria, and long-term alternate day prednisone, antihypertensive medication, and ACE inhibitors were used for this patient. When we make a differential diagnosis for children with hematuria, it's an important question. Is bleeding from where? From glomerular or distal part? Is there any associated systemic diseases or related any life-threatening condition? This a picture from one of my patients, and you can see this erythrocyte, dysmorphic erythrocyte. There is a satellite structure, and this is isomorphic erythrocyte, as you know, and this is dysmorphic. This is dysmorphic. And hematuria can be associated with vascular, interstitial, glomerular, or urinary tract. Vascular causes can be sickle cell disease or renal vein thrombosis or vascular trauma or nutcracker syndrome. It's a compression. And interstitial causes are infections, drug toxins, and anatomic problems, cysts, and neoplasms. And urinary tract problems, infections, urinary system stone disease, trauma, anatomic problems. And glomerular diseases can be primary or secondary, and some hereditary problems, including Alport syndrome disease. I don't want to talk about in detail for who these diseases, but I just want to underline, highlight for the first three. These first three are the most frequent: primary glomerular diseases, acute post-infectious glomerulonephritis, IgA nephropathy, thin membrane disease, and benign familial hematuria. And secondary glomerular diseases are hemolytic uremic syndrome and IgA vasculitis, and systemic lupus erythematosus are the most frequent ones. And what about extrarenal causes? After a severe exercise, we can observe hematuria, and it resolves within 24 hours. And fever, dehydration, gastroenteritis can cause hematuria. And some drugs, as you can see, NSAIDs, penicillin or cephalosporins can cause hematuria. Hematologic problems are rarely causes hematuria. Coagulation defects, hemoglobinopathies, and anticoagulant treatment and DIC can cause, but it's a very rare condition. Viral cystitis, bacterial cystitis, pyelonephritis can cause. And what about diagnostic steps? It should be rational, well-planned, and economic. We have to take a detailed history about gross hematuria, edema, any pain or dysuria, any recent or concurrent illness, trauma, or systemic symptoms, medication exposure, and is there any important disease in medical history and family history? For example, kidney stones or hearing problems. It's important for some glomerular diseases and genetic diseases. A physical exam provides us some clues about the etiology. For example, if we found a high blood pressure, we think about a renal failure, and growth failure may suggest a chronic kidney failure. Periorbital edema may suggest nephrotic syndrome or proteinuria. If we auscultate murmurs, grabs, gallops, and rails, we have to consider about hypervolemic condition. If there is a mass in abdominal part, we have to suspect about malignancies. Like that, you can see. And if there is a rash or petechia or purpura, we generally think about vasculitis. One further evaluation is required in the presence of symptomatic hematuria. It means edema, proteinuria, and hypertension, or persistent hematuria, hematuria with proteinuria, recurrent episodes of hematuria, and family history for glomerulonephritis or kidney failure, abnormal laboratory and or radiological findings, we have to evaluate in detail. And I would like to remind you the indications for kidney biopsy. If there is acute glomerulonephritis with severe hypertension and hyperkalemia, rapidly progressive glomerulonephritis, possible life-threatening conditions, bleedings, infections, we accept it as a pediatric emergency. We complete case 2. Just I have one case more if we have time. We have time. Okay. And I'm checking question and answer part. Okay. That's all clear and there's no question. Okay, we can continue. Okay. Case 3, a 1-month-old girl presents to emergency department with a day history of dark-colored urine, bloody urine. Prenatal, perinatal evaluations and labs unremarkable. Family history unremarkable. Birth weight, birth height normal. And dipstick test urinalysis revealed as 3+ blood, no protein. And on physical exam, we found mildly increased respiration rate, a severe hypertension, and a mass in the right abdominal quadrant. And I would like to summarize it. The problem lists are bloody urine, high blood pressure, and abdominal mass. How should be our first approach? Firstly, we treat hypertension. It's an emergent condition, and we use some IV medications like esmolol or nicardipine nitroprusside. At the same time, we start some oral drugs, ACE inhibitors, calcium channel blockers, or beta blockers, or diuretics. That's not our main subject now, but I just want to summarize it. Causes of hypertension in neonates are generally associated with renal vascular problems, thromboembolic problems, renal artery stenosis, or venous thrombosis, or coarctation of aorta in infants especially. We started to give nitroprusside, and you can see blood pressure decreased. And we think about the cause of hematuria in neonates. It can be renal vein thrombosis or artery thrombosis, or autosomal recessive polycystic kidney diseases, and obstructive uropathy, urinary tract infection, bleeding and clotting disorder, trauma, bladder catheterization, and other some causes can be happen. And what about abdominal mass and differential diagnosis? It can be hydronephrosis, severe hydronephrosis, or some cystic diseases, polycystic kidney disease, or multicystic dysplastic kidney disease, and renal vein thrombosis, and some solid tumors, or horseshoe or ectopic kidneys. And juxtarenal causes, neuroblastoma and adrenal hemorrhage, pheochromostoma, and teratoma sarcoma. And what studies would you like to perform? Urinalysis is very important to evaluate protein and erythrocytes in hematuria, and blood chemistry, urine electrolytes for renal functions, and catecholamines and urine homovalenic acid, vanillandelic acid, and some tumor markers, and renin for renal artery stenosis. And sometimes we use plain film to evaluate abdominal problems, and ultrasonography is the most important tool for us. Sometimes MRI and CT. When we're back to case 3, urinalysis showed us 3+ blood and large red blood cells, normal kidney functions, normal urine catecholamines, and increased alpha-fetoprotein. And this is plain graphy, and as you can see, there is no gases, and it may suggest a mass or enlarged liver. And via ultrasonography, we found a mass, and this is CT images. As you can see, a huge mass this part. And we considered about some malignancies. It can be a renal and adrenal origin, and mesobilitic nephroma and Wilms tumor and rhabdoid tumor can be happen. And in terms of adrenal problems, pheochromoblastoma or neuroblastoma can be happen. And what's the most appropriate treatment for our patient? Our patient underwent exploratory laparotomy and resection of mass, and we found pararenal immature teratoma with no malignancy. This is kidney tissue, and this is the mass. In summary, in a child with hematuria, generally hematuria resolves. If hematuria persists, long-term follow-up is often required, and in later phase, proteinuria, hypertension, and kidney functions follow-up are important. And if there's an abnormality in terms of kidney function or blood pressure, we decide to perform kidney biopsy. Again, I would like to remind you, hematuria can be a transient finding with no clinical findings, or an important marker of severe kidney disease. When you should refer to a pediatric nephrology in the presence of symptomatic hematuria or persistent hematuria or hematuria with proteinuria, recurrent episodes of hematuria, or family history of glomerulonephritis or renal failure, abnormal laboratory findings, radiological imaging, and if the family has a lot of anxious condition, you can refer patient to a pediatric nephrology, and we will be happy to help you about all these problems. If you have any question, you can ask. Okay, there's no answer, and thank you for your attention.
Good day and welcome. My name is Katerina Tikhonova. I'm from Ukraine. Me and my colleagues from different countries gathered here to help you and to give you the best medical care. Let me explain how the things are working here. First of all, we are receiving an email from you. It contains your request, all information about your disease, medical reports, MRI, X-rays, screens, etc. After that, we are sharing all that information with a certain doctor and taking his medical second opinion, which is MSO for short. The doctor prepares your own treatment plan accordingly. After that, we are taking the cost of that treatment plan from our accounting department and sending the offer to you. If you are accepting the program, from that moment you can start to prepare your plane ticket. We are also helping you with the hotel accommodation, transfers, and arranging your own translator. At your arrival day, we are meeting you with our VIP cars in the airport and bringing to the hospital. We are honored to know you as a Live Hospital family. We are ready to help you 24 hours a day, 7 days in a week. Live Hospital International Patient Service wish you a healthy days.
Здравствуйте, меня зовут Нигина Исмаилова. Я являюсь ответственным лицом по медицинским запросам в клинике ЛИВ для стран СНГ. Наша команда состоит из 40 человек. Мы занимаемся предоставлением второго медицинского мнения. Для этого пациент отправляет нам свои медицинские заключения, лабораторные исследования, если есть радиологические снимки. Специалисты клиники ЛИВ рассматривают и составляют план лечения и диагностики. Алгоритм требующихся обследований, а также их предварительная стоимость отправляется вам на почту. После того, как вы подтверждаете план диагностики и отправляете нам дату вашего приезда, мы организовываем вашу предварительную программу обследования. В случае надобности помогаем вам с резервацией отеля. Также предоставляем вам трансфер с аэропорта в аэропорт. Передаем всю вашу медицинскую информацию, отправленную вами, русскоговорящему переводчику, который будет вас сопровождать в период вашего пребывания в клинике. В день вашего приезда наши коллеги по логистике встречают вас в аэропорту и привозят в клинику ЛИВ. Сейчас вместе с вами посмотрим продолжение. Мы, как клиника Лив, гордимся тем, что нам предоставилась честь узнать вас. Отныне мы являемся частью вашей семьи и готовы вам помочь круглосуточно касательно вопросов вашего здоровья. Международный отдел клиники Лив желает вам благополучных дней.
Live Hospital, which promises to be the future of healthcare with its experienced patient care and guest-oriented approach, opened in Wadi Istanbul. It is that moment which makes you hold on to life, sometimes near a forest, sometimes in daily life. With its advanced diagnostic and treatment methods, that moment actually represents the future. There are some moments which makes you look to the future confidently. Those moments are the future. Live Hospital, the future of healthcare, opened in Wadi Istanbul.
В Вади, Истанбул, открылась больница будущего – Live Hospital, отличающаяся опытом в уходе за пациентами и гостеприимным подходом к своим пациентам. Порой расположение на краю леса, порой в жизни наступит момент, когда продвинутые методы диагностики и лечения помогут вам выжить. Этот момент обязательно настанет. Есть моменты, когда вы начинаете смотреть в будущее с уверенностью. Так вот это именно этот момент будущего. В Вади, Истанбул, открылась больница будущего – Live Hospital.
Merhaba, ben Profesör Doktor Levhi Akın. 2014 yılından beri Live Hospital Ulus'tayım. Genel cerrahi ve cerrahi onkoloji uzmanıyım. Aynı zamanda Tıbbi Yürütme Kurulu üyesi olarak idari bir görev de yapmaktayım. Şimdi beraberce Live Hospital Ulus'un içine gireceğiz ve sizler için hastanenin ne kadar güvenli olduğunu gösterebilmek için birlikte bir hastane turu yapacağız. Güvenlik ünitemizi geçtikten sonra tarama bankomuza geliyoruz. Burada uzaktan ateş ölçümümüz yapılıyor. Daha sonra yakın özgeçmişimizle ilgili bir takım sorular sorularak kayda geçiriliyor. Taramamız tamamlandıktan sonra taramayı başarıyla tamamladığımıza dair yakamıza bir etiket iliştirilecek. Hastanede bulunduğumuz süre içinde bu etiketi sürekli yakamızda taşıyoruz. Buyurun. Evet, içeri girdikten sonra önce danışmaya giriyoruz. Burada görmüş olduğunuz gibi sosyal mesafe kuralları açısından gerekli önlemlerimiz alınmış durumda. Girişten itibaren sarı çizgilerimizi devam ettiğiniz zaman onkoloji hastalarımız için özel olarak tahsis edilmiş olan asansörümüze ulaşıyorsunuz. Öncelikle şunu ifade etmek istiyorum. Bizler için en önemli olan şey sizlerin ve hastane çalışanlarımızın güvenliği. Biz sizlerin sağlığı ve tedavisi için buradayız ve hizmete hazırız. Misafirlerimize açık alanlarda ve bekleme bölümlerinde bir takım tedbirler aldık. Gördüğünüz gibi sosyal mesafe kurallarına uyabilmek için işaret gördüğünüz alanlara oturulmuyor, diğer alanlara oturuluyor. Oturulan alanlar her yarım saatte bir temizlik personeli tarafından siliniyor ve temizleniyor. Hastanemizde gerek hastalar, gerek ziyaretçiler, gerekse de refakatçilerle birlikte tüm hastane çalışanları için maske takılması zorunludur. Şimdi bir hasta muayene odasını birlikte göreceğiz. Zaten hep temiz olan yerler. Fakat bu dönemde biz bu işe daha çok konsantre olduk. Her hastadan sonra örtülerimiz zaten değişiyordu, gene değişiyor ama yüzeyler tekrar siliniyor. Sehpalar, her hastadan sonra sandalye kolları, kapı kolları, ışık düğmeleri hepsi temizleniyor. Ayrıca Türkiye'nin dört bir yanındaki hastalarımıza video klinik olarak da hizmet verebiliyoruz. Bilgisayar üzerinden kamera aracılığıyla sizler bizi görebiliyorsunuz, bizler sizi görebiliyoruz. Burada bilgisayardaki bütün sonuçlarınıza ulaşabiliyoruz. Tıpkı yüz yüze görüşüyormuş gibi sonuçlarınızı değerlendirebiliyoruz. Poliklinik hizmetlerimiz güvenli, acil servis hizmetlerimiz güvenli, tetkikleriniz güvenli, ameliyatlar güvenli. Ameliyathane güvenliği için de gerekli tedbirlerimizi aldık. Bu konuda şimdi ameliyathane sorumlumuz Profesör Doktor Didem Dal Hoca ile görüşeceğiz. Buyurun. Profesör Doktor Didem Dal'la birlikteyiz. Sayın hocam, bu süreçte ameliyatlarla ilgili ne gibi tedbirler aldık?
Bu hassas dönemde kesinlikle sağlığınızı ihmal etmeyin. Sağlığınız için gereken tetkikler, gerek bir ameliyat, herhangi bir işlem gerekiyorsa güvenle, doktorlarınıza güvenerek, hastanelerinize güvenerek gelebilirsiniz. Çünkü onlar sizler için, sizlerin güvenliği için tüm tedbirleri alıyorlar. Aynen kendi sağlıkları ve güvenlikleri gibi sizlere de her tür hizmeti sunmaya hazırlar. Bizler de bunları yapmaya çalışıyoruz.
Benimle bu hastane turuna katıldığınız için teşekkür ederim. Live Hospital Ulus'u sizler ve hastane personelimiz için mümkün olan en güvenli hale getirdiğimizi umuyoruz. Sizler için buradayız ve hizmete hazırız. Tedavilerinize devam etmek istiyoruz. Unutmayınız, güvenliyiz ve sizi de güvenli tutmak için buradayız.
I would like to share my screen. Peki burada niye? Hi again. Görülüyor mu? Okay. Hi, my name is Dr. Şenol Bekmez. I am a pediatric orthopedic surgeon and associate professor of orthopedic surgery, working in Live Hospital Group, Istanbul. And first of all, I owe a special thanks to the organization committee for providing me this opportunity to make my presentation. And our topic is approach to orthopedic problems in childhood. And we will do case-based discussions. And my first case is a 6-year-old girl admitted to my orthopedic clinic with her parents with a complaint of limping and limb length discrepancy. She has no pain at all. And main problem was discrepancy in leg lengths. In the examination, her left lower extremity was 5 centimeters short, and in daily life she's using 4 centimeters show lift. And as you can see in the picture, she has 4 rays in the left foot. And when we do this alignment X-ray, we realize that a 6 centimeter support under the left foot makes her slightly longer in the left side, because as you can see here, the left iliac wing is around 1 centimeter higher. So her exact discrepancy is 5 centimeters. And when we measure radiographically, 2.5 centimeters is coming from the femur, and the other 2.5 centimeters discrepancy is coming from tibia. And as a manifestation of fibular hemimelia, her left fibula is shorter. And you can see this deformity in the left ankle, which is called ball and socket ankle, which we commonly see in fibular hemimelia. She has minimal equinus deformity, and fortunately, she has no instability in the knee and the ankle joints. So her diagnosis is fibular hemimelia, which is the most common congenital long bone deficiency. We call it common, but it's still very rare condition, 1 in 40,000 live births, but it is the most common congenital long bone deficiency. And it is not just disease of the fibula, it involves the entire limb, as I will mention in the next slide. And the classical presentation is the anteromedial bowing of the tibia. And as I told you before, there are several orthopedic manifestations, and this disease is involving the entire limb, not only the fibula, including ankle instability, ball and socket ankle, as I showed you in the X-ray. They usually have pes equina valgus deformity, and rarely when there is tarsal coalition, rarely we can see equina varus deformity. And tarsal coalition is associated in 50% of cases. As I showed you in the clinical picture, they usually have absent lateral foot raise. And they usually have femoral abnormalities like coxa vara deformity and knee valgus deformities. They can have hip dysplasia, they can have cruciate ligament deficiency, which can create a problem in lengthening surgeries. They usually have genovalgum deformities, and it is associated with significant leg length discrepancy. So if we go in the first slide, so we have some sophisticated calculations to predict the projected limb length discrepancy when a 6-year-old girl becomes adult. It means when we have 5 centimeters discrepancy now in 6 years, we can predict what will it be happen in age 14 in a girl, which is called multiplier method, described by Paley, Dr. Dror Paley from United States. And several studies demonstrated that it is very effective and very reliable in children among different genetic and geographic background. So it is really reliable. So for this case, we predicted that the projected limb length discrepancy will be 7.8 centimeters. Currently it is 5 centimeters, but at the end of 14 years old, it will be 7.8. So in our case, we decided to do a limb lengthening procedure. And we decided to do tibial lengthening. And it is a picture from the operating room. We put these rings and strut external fixator systems, which allows us to do a gradual lengthening and correcting the deformities at the same time. And it gives us, I think the biggest advantage of this system is it allows us to fine-tune our lengthening or our deformity correction during the treatment period. So it is a very, very versatile system. And second advantage, it allows to full weight bear. So it is post-op X-ray from the day one day after the surgery. You can see the osteotomy in the proximal tibia and the rings and the pins and the fixator in place. In those cases, we always stabilize the ankle joint and put this screw. And you can see here, it is day 7. You can see the gap in the osteotomy site. And these pictures are in day 30. So you can see that the gap is bigger now, and it is now body is filling the defect with bone. We call it destruction osteogenesis. So to achieve this good quality bone, the rate of the lengthening should be an ideal velocity. If we do it too fast, it can diminish the healing. If we do it too slow, we can see early consolidation. So when we do this operation, we follow the patients weekly by X-rays to make sure that everything is good. There is good quality bone formation in the osteotomy site. So this is a clinical picture in day 30 when we get 3 centimeters lengthening, and our aim is to have 5 centimeters lengthening in the tibia. When the bone completely heals, we will remove the fixator. This is our second case, which is an 18 months old girl presented with limping, and she's the first child. There is no family history for any orthopedic condition, and unfortunately, she didn't get any screening for hip dysplasia, either clinical examination or ultrasound screening. She got nothing, and she presented limping in the walking age. As you can see in the X-ray, in the left side, in the normal hip, we can see that the inferior margin of the femoral neck and the inferior part of the pubis is aligned. We call it Shenton's line. It's a aligned semicircle. But in the right side, you can appreciate that the Shenton line is broken. The two lines are not connecting. And you can see the high riding dislocation, and the ossific nucleus of the femoral head is smaller than the left side. At birth, the femoral head is all cartilage, and eventually, at the end of 4th month, the femoral head starts to ossify in a small spot, which is called ossific nucleus, and it gets bigger with time. And we know that when the hip is not reduced, it means when the ball is not in the socket, this ossific nucleus formation delays. So it's a very classical demonstration of a high riding developmental dysplasia and underlying dislocated hip. You can see the ossific nucleus. And again, you can appreciate that in the left side, the socket, it means the acetabulum is well developed, it's deep. But in the right side, the acetabulum is quite deficient and steep. So our diagnosis is developmental dysplasia of the hip joint. And this disease is a spectrum, including dysplasia. It means only abnormal acetabular morphology in the benign cases. And it can be, again, it can be a subluxation, or it can be the frank dislocation in the most severe part of the disease. In DDH, hip joint anatomy normally develops during embryogenesis, but starts to diminish at the 3rd trimester. It means the hip joint keeps developing after the delivery. This is why the terminology changed 20 years ago, and we don't name it congenital dislocation anymore, because this is a developmental disease. In the 1st trimester, in the organogenesis, the hip joint development is normal. But because of the position of the baby during pregnancy, the hip slightly comes out. So this is why now in the modern terminology, we call it developmental dysplasia of the hip. But again, still there is a small patient group which has dislocated hip joint from the beginning. And this is called teratologic hip dislocation. It's a very small group of patients, and they are usually associated with genetic syndromes. So for DDH, risk factors are being a girl, being the first child, breech presentation during the pregnancy, positive family history, oligohydramnios, swaddling is a very well demonstrated risk factor, and ligamentous laxity. This ligamentous laxity is mostly coming from the maternal hormones from the pregnancy. And according to the theory, because girls are more sustainable to these hormones, this is why girls are more commonly affected. And as I told you before, DDH is a packaging syndrome. It is about the abnormal position of the baby during the pregnancy. And it is associated with the other packaging syndromes, such as metatarsus adductus and congenital muscular torticollis. So when we realize that a baby has metatarsus adductus, we need to be very careful, and we have to reevaluate the baby in terms of any hip pathology. In the natural history, at the beginning, the hip joint is morphologically normal. Only there is steep and mildly deficient acetabulum. And other contributing factor is ligamentous laxity, as I told you before. And then the hip joint slowly become to come out. And then body fills the empty acetabulum with connective tissue, which is called pulvinar tissue. And the ligamentum teres capitis starts to elongate and thicken. And we see the hypertrophy of the transverse acetabular ligament, and the hip capsule as well becomes elongated, which is called hourglass appearance because of the psoas tendon pressing in the middle. So they become some barriers to reduce the hip joint. So in the DDH, initially the hip is reducible. The pathology is dynamic. But with time, if the hip comes out, and if it is a long-lasting dislocation, some secondary barriers starts to develop, which blocks our reduction. And then with time, some secondary bony abnormalities happens, which is called femoral deformities and acetabular deformities. And after some time, it means, for example, after 7 or 8 years, because of the bony anatomy is distorted, then the reconstruction to put the hip joint in the socket becomes impossible. So early detection and screening and early intervention is critical in a successful outcome. In the physical examination, there are some routine examination methods. First of all, the first one is ortolani sign, which is Klankov reduction, which means the hip is dislocated, but we are able to reduce it. And when we abduct the hip joint, affected hip joint, which is left side in this baby. So I would like to point the position of the fingers. So index finger is pressing over the GT, and when we abduct the hip and pressing under the GT, we feel a clunk sign. We can feel the reduction. And if we feel it, it means the hip is dislocated, but we are able to reduce it. It is called ortolani sign. And on the opposite, Barlow sign is the clunk of dislocation. It means the hip is reduced, but we are able to dislocate the hip joint. It is another sign of the instability. So in this examination, we bring the hip to adduction and press over the lesser trochanter with using our thumb. When we feel this clunk, it means the hip was reduced, but we are able to dislocate the hip. This is called Barlow sign. And when one of the hips are out, it creates asymmetrical abduction, which is another examination findings in bigger kids. After 6-7 months, the hip, previously reducible or dislocatable hip, becomes fixed dislocation, and it creates abduction deficit, which causes asymmetrical abduction. But we need to be careful when we are assessing the abduction, because if we have bilateral dislocations, bilateral high riding dislocations, the abduction is limited on both sides, but it is still symmetric. So we can easily think that the hip is bilaterally normal, but we have bilateral dislocated hips. And Galeazzi sign again indicates a dislocated hip when we bring the hips and knees to 90 degrees flexion. Knees have to be leveled. If there is more than 1 centimeters discrepancy, it means the affected shorter side is abnormal, which is called Galeazzi sign. And it is another physical examination finding in late presentations. So to detect the hip problem early, the first line method is physical examination, but in babies with risk factors, it's highly recommended to do a hip ultrasound. And worldwide, mostly used method is graph technique, and we evaluate the shape and deepening of the acetabulum, and we can detect any instability or dysplasia early, and we can easily fix it with using conservative methods. Otherwise, if we don't screen babies with clinical examination and ultrasound, in maybe 4 or 5 of every 1,000 babies, we can end up with a X-ray like this in walking age. And we miss the opportunity to do the conservative methods. So this baby needs a surgery. But if we detect earlier in the first 3 months of life, we have the opportunity to fix it with bandage, which is called Pavlik harness method. So in the first 6 months of life, when we detect the DDH early with physical examination or ultrasound, we use Pavlik harness method, which is a dynamic brace, directs the femoral head nicely and gently to the acetabulum, to the socket. And the success rate is almost 90%. When the pelvic harness is not successful in some fixed dislocations, pelvic harness is not working, or when we have a delayed presentation, still before the walking age, we do close reduction under anesthesia and do hip spica's. But in some cases, so when we are doing a close reduction under anesthesia in the operating room, we are always prepared to do an open surgery, because sometimes it is not, even under anesthesia, it is not possible to bring the ball into the socket. There are some secondary barriers, as I mentioned before. Then we need to do an open surgery. And after age 18 months, only open reduction is not enough, because acetabulum is too steep and deficient. So we need to reshape the acetabulum to have a deep socket across to the ball, which is called femoral head. And most common method, there are some different methods, but the most common method is the Salter osteotomy. We cut the pelvic bone, redirect the acetabulum, and put a bone graft, triangular bone graft into this defect. If you don't treat a high-riding DDH, so this is the natural history. So it affects hip joints. It can cause arthritis and pain in early age. And it also affects the spine. You can, in this picture, you can appreciate how the lumbar lordosis increase because of the bilateral dislocated hips, and the patient has limping, which is called Trendelenburg gait. And they usually end up with hip arthroplasty in very early age, like age 20s or age 30s, which we usually don't want to do hip arthroplasty in this age group. So as one of the legends of the pediatric orthopedic surgery, Mercer Rank, which was a retired professor in the hospital sick children, which I also did my clinical fellowship, has the word. He says no child has ever benefited from a dislocated hip. So a kid with dislocated hip has to be treated to avoid suffering from arthritis or disability in adult age group. So let's return to our case. For this case, because she was 18 months, we decided to do surgery, including adductor tenotomy, and we did an open reduction, anterior open reduction, with using Smith-Patterson approach. And we released the secondary barriers like psoas tendon, adductor longus tendon, ligamentum teres, and transverse acetabular ligament. We resected the pulvinar tissue inside the hip joint, and we reduced the hip joint, and we did a Salter pelvic osteotomy. So this is the post-op X-ray, which shows the Shenton's arc is now intact. The head is into the acetabulum, and you can see that we also corrected the acetabular morphology with doing the Salter osteotomy and putting a triangular bone graft in the osteotomy site. And she will stay in a spica cast for 6 weeks, and then we will remove the cast and we will let her to walk without limp. And this is our third case. So he admitted to us with abnormal walking and clumsiness, because as you can see in this video in the left side, he has in-toeing gait. And in the physical examination, revealed that there was no coronal or sagittal plane deformity, but there was a axial plane deformity, which is called rotational deformity. The hip joint was normal, femoral anteversion, internal and external hip rotations were normal, but as you can see in this picture, he had increased internal tibial torsion, which is measured by clinically by thigh foot angle. This line in the thigh and the line in the foot normally should be at least 15 degrees external, but in this 10-year-old boy, it is 15 degrees internal. So our diagnosis is internal tibial torsion. Internal tibial torsion actually very common in kids less than 4 years old age. And the diagnosis is made with clinical test, as I showed you, with using the thigh foot angle measurement. If it is more than 10 degrees internal, and now our diagnosis is internal tibial torsion. This problem is often bilateral. Exact etiology is unknown, but possibly caused by intrauterine positioning, like metatarsus adductus. And luckily, this condition usually resolves by age 4 without doing any intervention. And surgical treatment is only indicated in children more than 8 years of age with functional problems and internal thigh foot angle more than 15 degrees. So in this case, we decided to do bilateral tibial derotation osteotomies and fix that with using these plates and screws. And in these types of operation, the most common site for correction is supramalleolar region, as we did in this case. And in this picture, you can see that after the operation, we corrected the thigh foot angle. Now our thigh foot angle is 15 degrees external. And after 6 weeks of cast, when we see the osteotomy is healed, we will let him to walk independently without using any assistive device. Now this is our fourth case, which is admitted to my clinic with a complaint of pes planus, a foot deformity. He has pain and discomfort and problems in adjusting shoe wear. He had a previous operation 3 years ago, but it's obviously not successful. So you can see in this picture in the left side, the heel is turned out, and you can see in the picture in the right, the medial longitudinal arc is collapsed. And this pre-op X-ray standing on the cassette reveals that it shows the previous operation. They put a screw in the subtalar joint with an idea to block subtalar motion and lock it in immersion, which is called arthroeresis technique. But it didn't work, and the screw is broken. You can see here in the AP view, you can see that talar head is uncovered by the navicula. It is almost 15% covered, and the line in the longitudinal axis of the talus is not aligned with the first ray. And in the lateral X-ray, again, the longitudinal line in the talar head and the line of the first ray are not aligned and it is broken. It's called Mayer angle, and it shows the collapse in the medial arc. And again, the calcaneal pitch angle is reduced. So the diagnosis is pes planus, and the pes planus is actually very common in children. It is maybe the most common cause to admit to a pediatric orthopedic department. And mostly it is flexible pes planovalgus, which is associated with generalized ligamentous laxity and lower extremity rotational problem, usually bilateral, and treatment is not indicated, and most cases resolve spontaneously. But there are some rare but other conditions which might require intervention. Not only every single pes planus are benign. Some of the cases are real severe, can cause discomfort and pain, and they need treatment. So one of these conditions is flexible pes planus with a tight heel cord. And in those cases, like our case, surgery is indicated in continued refractory pain despite use of extensive conservative management. And there are another less common cause of flat foot, which is called rigid flat foot. This is rigid because there are some connections in the small bones of the feet, which is called tarsal coalition. And they need surgical intervention. But our case, he had flexible pes planovalgus with tight heel cord. So we decided to do an operation, and first of all, we removed this previous screw, and we lengthened the tendo Achilles with Vulpius technique. And then we did a lateral calcaneal lengthening osteotomy described by Evans. And when we lengthened the calcaneal bone on the lateral side, we put a fibular autograft in the osteotomy side. And we transferred peroneus brevis to peroneus longus tendon to correct the dynamic forces which is causing the deformity. And we did reefing to the soft tissues on the medial side of the foot. And again, we did medial cuneiform plantar close-wedged osteotomy to increase to drop the first ray and increase the medial arc. So those are intraoperative X-rays. And this is post-op 3 months standing X-ray, which shows in the AP, now the talar head is nicely covered by the navicula, and the longitudinal axis of the talus is very well aligned with the first ray. Again, in the lateral side, the talus is very well aligned with the first ray, and you can see this calcaneal pitch angle increased. And clinically, you can see here, now in the back side, we have a very nicely straight heel. It's not outward. And in the picture in the right side shows the medial longitudinal arc is very nicely reconstituted. And our fifth case is a 5-year-old boy whom is diagnosed with cerebral palsy. He is functioning in gross motor function classification system 5. It means he is a very demanding patient, which is dependent to wheelchair. He has tracheostomy, he's feeding with G-tube, and he has very frequent uncontrolled seizures. And he admitted to my clinic because of the deformity on his legs, and he's not able to sit on a wheelchair, and he needs to, every time he needs to lie spine, and he's aspirating what he eats, and he has recurrent pulmonary issues. So cerebral palsy is the injury of the immature brain that leads to upper motor neuron disease. And it is very common. The incidence is 2 to 3 per 1,000 live births. And the pathology starts with abnormal muscle tone, which eventually becomes contractures and bone deformities. And in orthopedic surgery perspective, we use gross motor function classification system to classify the patients according to their functional levels. And it is very helpful to make a treatment plan and to detect our treatment goals. And we grossly classify the patients into two. In the first gross motor function 1, 2, 3s are independent walkers, and 4 and 5s are wheelchair dependent. So treatment goal should be different on those different patient groups. And as you can see here, according to the gross motor function level, starting from birth, every kid has some progress, some positive progress in terms of functional capacity. They reach to a threshold, and then it becomes constant. It's usually around age 8. So we can grossly say that the functional capacity of the kid with a cerebral palsy in age 7 and 8 can be projected to adult life. And as in our patient, in non-ambulatory patients, wheelchair dependents, most common problems are spine deformities and hip problems. And we usually, in these non-ambulatory patients, we usually have very huge problem list, including seizures, cognitive impairments, dysphagia, malnutrition, constipation. And in orthopedic perspective, they have severe contractures and bone deformities, including spine and limb deformities. And where should we start? So the first question we ask as orthopedic surgeon, I always ask myself that, will the patient survive after surgery? And am I really helping this kid when I'm operating this patient? And we need to optimize the general health status before any kind of surgery. If there is malnutrition, the patient needs to have G-tube first. Sometimes to increase bone quality, we use bisphosphonates. And before big orthopedic operations, we usually ask neurology to modify anti-seizure medications, because we know that some of them can cause substantial bleeding during and after surgeries. And for a wheelchair-dependent kid, for this kid, so it doesn't make any sense to make a very big operation to correct this huge, complex foot deformity. So I can have a very nice, good-looking result, but actually it is not helping to the patient. So it is meaningless. So to detect these treatment goals, we need to use an integrative approach, and we can really connect with the patient and caregivers and their expectations. We need to take them into account. So for this kid, as you can see here, hips are out. But when I examine this kid, hips are out, but it doesn't cause any pain or discomfort. We can always intervene to the hip joints if they become symptomatic. But the main problem for this kid is his knee deformities. He is not able to sit on a standard chair because his knees are bending back. So these pictures are under anesthesia. When I bring these hips to 90 degrees flexion, he has only 20 to 30 degrees knee flexion, which means there is a very severe contracture in the quadriceps muscle. So I decided to do a quadriceps VY+T lengthening. And this is just after the surgery, and now we have 90 to 100 degrees knee flexion on both sides. And this is post-op day 2. My patient is very happy because he's now able to sit on a wheelchair. So it means in kids with underlying neuromuscular condition, we need to customize the treatment. We are not treating the X-rays. We are treating the patient. So we need to customize our approach in every kid and the kids and the caregivers' expectations. So this is our case 6. Another interesting case, which is 13-year-old active, otherwise healthy boy, who is suffered from left femur neck fracture 2 months ago after a simple fall. And unfortunately and interestingly, he admitted to a local hospital, and they decided not to operate this fracture, which is 100% indicated for surgery. And he had bed rest for 2 months. And this is the frog leg X-ray, which shows the displacement in the fracture site. And in the physical examination, he's able to, after 2 months of rest, he is able to walk with crutches, but he still has some pain. And the left side is 2 centimeters shorter than the right side. And the range of motion in the left hip is slightly painful on the left side. And he has limited abduction, probably due to the trochanteric impingement, because when he abducts the left hip, the trochanter major impinges to the acetabulum. And he has a slight decrease in the hip flexion on the left side, and he has an external rotation deformity, which is called retroversion in the left hip. His left hip internal rotation is only 10 degrees. And in the examination, he has decreased femoral anteversion in the left side. And this is the standing AP X-ray. And we had a CT to further evaluate the fracture site in 3 dimensions, which is called some bone healing, very small amount in the fracture site. But the fracture is quite displaced. And we use these 3D reconstructions to have a better idea about the fracture configuration. And the adduction and abduction X-rays revealed that there is no pathologic movement on the fracture site. The leg is moving as a one single unit. So it means there are some healing on the fracture site. So our diagnosis is femoral neck non-union. It's a very rare issue in children population. And we decided to treat it surgically. We decided to do a subtrochanteric femoral valgus osteotomy for different reasons. First of all, we aim to convert the shear forces in the fracture site to compressive forces to facilitate the union. The second aim of doing this valgus type osteotomy was to restore abductor moment arm to correct limping. And the third goal is to correct the limb length discrepancy. So I usually use a software method to do my surgical planning before complex cases. So I did in this kit, as you can see here, I planned my osteotomy site and I simulated my surgery. And this is what exactly I did in the operating room. And I did the surgery. Now you can see here, the trochanter tip is exactly in the center of the femoral head, like in the right side. We corrected the abductor moment arm, and we also corrected the limb length discrepancy. And after 2 months, X-rays revealed that the non-union site is healed very nicely. And the patient now pain-free, not using any assistive device, and the rotational profile is perfectly symmetric. And it was a very successful outcome. So my last case is a 5-year-old girl with a history of multiple fractures since birth. And she has a family history of a rare bone condition, and she's unable to walk. And the diagnosis was osteogenesis imperfecta. And as you can see here, because of the multiple fractures, she has huge deformities on the femur and the tibia. So osteogenesis imperfecta is a mutation in collagen 1 gene and abnormal collagen cross-linking and overall decrease in type 1 collagen causes fragility fractures, spine deformities, and also hearing loss and cardiovascular abnormalities. And the treatment in osteogenesis imperfecta is a multidisciplinary approach for fracture prevention with bisphosphonates and fracture management when present, and realignment osteotomies for long bone deformities as we have in our patients. Again, as I used my software system to simulate my osteotomies. And I did femoral and tibia osteotomy on the left side in the same stage, and fixation with telescopic nail, which allows which avoids the deformity because it is engaged to the proximal and distal part of the bone, and the bone lengthens as straight as possible. And this is our outcome. The picture in the operating room and the X-ray reveals that we had a very nice correction, and we used this telescopic rod, which has a female and male parts engaged to the growth plates, and as the bone grows, this implant keeps the bone straight. So thank you for your patience, and I'm finishing my presentation now, and I would be more than happy to answer any questions or comments. Thank you.